Okay, so welcome everyone to today's press conference. My name is Salah Scheider from the Ontario Health Coalition, and I'm just going to introduce the press conference and go over a few housekeeping things before we move on to the speakers. So today we're holding a press conference with provincial health coalitions from across the country that will share real-life accounts of what has happened on the ground in their provinces as a result of the privatization of public hospital surgeries and diagnostics to for-profit clinics, as well as other forms of privatization in healthcare. We'll have briefings from the different health coalitions, and then we'll open it up to the media who are on the Zoom for questions. We are also hosting this press conference via Facebook live stream and Twitter Spaces. And if there's time at the end, after the media have an opportunity to ask their questions, we'll open the floor for questions from the viewers watching on Facebook and Twitter. Maddie, can you introduce yourself and introduce what we're doing with the Twitter Spaces?
Hi, everyone joining us on Twitter. My name's Maddie, and I'll be taking your questions at the end of the press conference if we have time from Twitter Spaces. So if you have a question, please put the question in the replies to this tweet. Thank you.
Thank you, Maddie. And Lubaba, can you introduce yourself and the Facebook live stream?
Hi, everyone. I'm Lubaba from the Ontario Health Coalition. I'm one of the other campaigns organizers for Ontario. I will be monitoring our Facebook live stream. So if you're tuning in from Facebook, feel free to leave your questions and comments in the comments section below. And I'll be monitoring them and bringing them up. If you could kindly leave your questions, they will be answered towards the end. Thanks.
Thank you, Lubaba. And with that out of the way, I will pass it off to Natalie Mera, who's the Executive Director of the Ontario Health Coalition. Natalie?
Thank you very much, Salah, and thank you everybody for being here. We asked the provincial health coalitions from across the country to join us today to share with us what's happened in their provinces where private clinics have already been set up to take surgeries and diagnostics out of local public hospitals and privatize them to for-profit clinics. As you know, last week, Bill 60, which is the Ford government's privatization of our public hospitals legislation, was passed in our provincial legislature to pave the way to do the same thing in Ontario, to cut the surgeries and diagnostics from our local public hospitals and transfer them to private for-profit clinics. In his press conference in January, on January 16th, Premier Ford said that 50%, in his government's assessment, 50% of the surgeries in Ontario are of the easy sort, the type that they would like to privatize. Initially, the government has done work to set up 3 for-profit day hospitals in Windsor, Waterloo, and Ottawa to do cataract surgeries and then diagnostics. They would like to expand that. They are expanding the private clinics now. They would like to have for-profit hip and knee surgery clinics up and running by next year. We're doing everything in our power to stop this. And I think we wanted to really, in very concrete terms, hear from the other provinces what has happened in their hospitals and their healthcare system as a result of this kind of for-profit privatization of our public hospitals across the country. We already have a little bit of experience of this in Ontario. I mean, by and large, most of the vast majority of our surgeries and diagnostics are done in our public hospitals. But in 2001, the Harris government tried to privatize cancer treatment, and it brought in a for-profit cancer treatment center near Sunnybrook Hospital. The provincial auditor did an audit of that cancer treatment center and found that it cost $500 more per treatment. That was in 2001 dollars than the public cancer treatment centers. It had also been given $4 million in public money to cover their startup costs. Ultimately, the auditor found that it did not reduce wait lists. And obviously, if it costs so much more per treatment, the same investment in public cancer treatment would have reduced wait lists much faster and for less money. And ultimately, that for-profit cancer treatment center was closed. The government also tried to bring in a number of for-profit MRI and CT clinics in Ontario. From that experience, we have concrete evidence which the Toronto Star actually dug up. Teresa Boyle from the Toronto Star that the University Health Network scaled back its hours of operation for its publicly operated MRI because it lost technologists to one of the new private MRI clinics. Similarly, Kingston General Hospital lost MRI techs to the for-profit clinic and was forced to reduce its MRI operations as a result. And the same thing happened to the Windsor Hospital, which lost MRI technologists to the Kitchener Clinic. We also have the very potent example of LASIK MD eye surgery. In 2004, founder Mark Cohen announced to the media that the physicians were going to opt out of Medicare. A number of the physicians for LASIK MD were going to opt out of Medicare to charge patients directly for surgeries. A few months later, he changed his tune and announced to the media that they would continue to operate within the public healthcare system, but they would charge patients for laser eye surgery, which they would attach to cataract surgery in order to extra bill the patients. He said that this was a, quote, loophole in the Canada Health Act, that they would charge patients for their laser surgery, not their cataract surgery, and therefore get around the Canada Health Act's ban on extra billing patients for medically necessary services. In Canada, you cannot charge a patient for medically necessary hospital or physician service. That includes your surgery, that includes your diagnostic tests, that includes the tests associated with that surgery, the nursing care, the blankets, and so on. And yet the private clinics, ever since the beginning in the early 2000s, have started to upsell patients, commingle, attach their surgeries to medically unnecessary services in order to upsell to patients and extra bill patients directly for their surgeries in violation of the Canada Health Act. And so today we wanted to hear from the other provinces about how this has played out across the country in the intervening years. You know, have we lost staff from public hospitals to the private clinics? Are patients being upsold and extra billed in the private clinics? Are there quality problems and other problems like that in the private clinics, as we've seen in the endoscopy clinic in Ontario, where faulty sterilization meant that almost 7,000 patients were potentially infected but with HIV and hepatitis and had to be tested for that, or like in the colonoscopy clinics where where poorer quality was found and more missed cancers were found, or as in the for-profit hospitals in the United States, where they have significantly higher death rates than in the public and not-for-profit hospitals. And so here, with a kind of real-world experience and a warning for Ontario, are the provincial leads for health coalitions across the country. We're going to go west to east today, and I've put the first name in the chat. It's Noelle Amir, and she is the campaigner for the British Columbia Health Coalition. Thanks, Noelle.
Hi, everyone. If anyone wants to understand the reasons why Bill C-60 is not the answer to the surgical and diagnostic backlog issues, we don't have to look further than British Columbia. Here, we've spent the past 14 years fighting the Cambie case in court to prevent the situation that is actually happening in Ontario, because we saw downstream the impacts of what a two-tiered healthcare system would have on access to equitable healthcare. And on April 6th, of 2023, the Supreme Court of Canada dismissed the Cambie leave for appeal in our favor, and it prevented a case which would have dismantled the public healthcare system from being able to function properly. At stake in this case was a restriction on private clinics from extra billing, both the public insurance plan and the patient. So allowing for-profit clinics to do this leads to a two-tiered healthcare system that would actually benefit the wealthy and the healthy at the cost of the most marginalized people who can afford to pay to jump the queue, but may have the most need for timely healthcare. In 2020, the Cambie case was in front of the BC Supreme Court, and the court ruled in favor of public healthcare. they released a landmark decision that was 800 pages long that found that a two-tiered healthcare system would not actually shorten wait times, they would make them longer. The evidence presented at the BC Supreme Court also decisively showed that a two-tiered system undermines access to equitable care. It adversely affects long-term sustainability of our public healthcare system, and it creates perverse incentives for physicians to upsell an extra bill. While the case was fought in court for 14 years, private clinics have extra billed patients in that time, meaning that surgical and diagnostic providers simultaneously charge the medical insurance plan in British Columbia as well as patients for insured services. And the attempt to rein in this illegal practice, which is against the Canadian Health Act, the federal government withheld they withheld federal health transfers on a dollar for dollar basis. So essentially for every dollar extra billed in the province, the federal government withheld funding for the public healthcare system. So this means that patients are paying double, not only losing funding to the public healthcare system, but then also having to pay to access public healthcare. But these aren't the only consequences of a private healthcare system. Increasing for-profit involvement in our healthcare system will increase wait times, because at issue is a two-tiered healthcare system that essentially is operating on the same workforce. And that workforce can't be in two places at once. Operating room capacity can increase, but we're drawing on a limited labor force. So until we can expand that labor force, we're not actually going to solve this problem. Another challenge of the two-tiered system is that private for-profit clinics can be selective. As Natalie mentioned earlier, they can opt to take on less complicated cases, and this has been the case in British Columbia. That means that patients that have more complex care needs often have to rely on the public system, and in a two-tiered system, that means that that public system is facing more and more constraints on resources and capacity, which means that it further marginalizes people who are impacted by and need equitable access to healthcare. There have also been instances where patients who suffered complications as a result of receiving surgery from a private clinic, and they were actually referred to go to the hospital instead of continuing care within the private for-profit clinic. And so often these private for-profit clinics can boast that they have better outcomes, but this is only a half-truth. Another documented issue with private for-profit clinics in British Columbia that we have seen is upselling. And when the duty to deliver care is replaced with profit motives, private companies who have a duty to their shareholders will go to great lengths to increase their profitability. And that includes doing things like recommending unnecessary procedures to patients. And we've seen this happen in British Columbia. All the provinces and the federal government need to come together to improve access to surgical and diagnostic services by increasing capacity in the public system, by growing our workforce. Expanding the private for-profit system is a short-term and short-sighted solution. It's not going to address the root cause, and it's actually going to make our public healthcare system worse off.
Thank you very much, Noelle. And next we have Chris Galloway, and Chris is the Executive Director of the Friends of Medicare in Alberta.
Thank you, Natalie. As Natalie said, I'm Chris Galloway. I'm the Executive Director at Friends of Medicare here in Alberta, joining you from Treaty 6 territory in Edmonton, where it's actually quite smoky today because of the wildfires. So sorry if I get a bit of a cough while speaking, because it's very smoky in the air today. But here in Alberta, we have a long history of privatization schemes in healthcare that I could bring a warning about: ophthalmology, seniors care, food services, MRIs. The list of examples of schemes in privatization that we've tried here, where we put profit ahead of patient care, is long. A recent example in December, which impacts people's ability to access their care, was when Alberta turned over a large chunk of our lab services to Dynalife, a for-profit corporation. Ever since then, we've seen chaos and delays in the lab services system, we hear almost daily from folks in Calgary or Southern Alberta who are looking at 6 weeks to get an appointment for their basic lab work or are unable to get urgently needed lab work. And just a couple of days ago, we heard from folks in Medicine Hat who were told to go to the emergency room in the public hospital to get their testing done because they couldn't get an appointment for urgent testing. So we see what privatization does to care. But what I really want to talk to you about today is the Alberta Surgical Initiative. I think it's most relevant to what's happening in Ontario right now around surgeries. The ASI here in Alberta represents the largest expansion of for-profit corporate care in Alberta that we've probably ever seen. We're using our public healthcare dollars to fund the creation and then operation of private for-profit surgical centers. And in a luck of good timing, just this morning, the Parkland Institute at the University of Alberta actually released a new report looking at the last 3 years of the Alberta Surgical Initiative. And the report's titled Failing to Deliver, the Alberta Surgical Initiative and Declining Surgical Capacity. And it lays out clearly what Natalie and Noel have talked about in terms of the issues with creating a parallel two-tier system. So some of the conclusions in the report I want to highlight. The Alberta Surgical Initiative increased public sector staffing shortages and destabilized our public hospitals. The government said over and over again that this initiative would increase the number of surgeries performed in Alberta. It did not. We failed to meet the government surgery targets as surgery activity in public hospitals declined while for-profit facilities focused on lower complexity procedures, leaving many people waiting even longer for their surgeries. It did not address wait lists. It did not address the number of surgeries performed in the province. And it did all this while costing us more, which the report flags will get worse over time as we entrench these for-profit providers in the system. We're going to reduce our ability to negotiate prices for these surgeries. And that's especially true as we begin already to compete for spaces in these centers. For instance, Saskatchewan right next door is already looking at sending patients into Calgary to get surgeries done. So it's going to be a race to the bottom in terms of price. But it's not just about other provinces and other jurisdictions, it's about individuals. The report raised many concerns about unlawful extra billing and two-tiered healthcare. These clinics claim there's a loophole in the Canada Health Act where individuals can pay for care in a neighboring province, meaning these centers allow for folks from other provinces to come into Alberta to pay for their surgery and to skip the queue and get their surgery done quicker by coming here to Alberta. That means those who can afford to travel and have tens of thousands of dollars to pay can get to the front of the line, while everybody else is left waiting even longer for care. We think that's unacceptable. It's a story we've heard regularly in the media here for months. There's been many folks who talk to the media about their choice to pay or how long they're waiting for these surgeries. We think it's totally unacceptable. It goes against the Canada Health Act. I would leave it at that, but I would just encourage everyone to check out that report. It also looks at Saskatchewan and what happened there with the Saskatchewan Surgical Initiative a decade ago, which sees the same conclusions, that they created a two-tier system, they increased privatization, and it didn't deal with their surgical backlog or their wait times. So I would leave it at that, and thank you for the time.
Thank you very much, Chris. And we should note that the prices in the private clinics are just outrageous. They're ludicrous prices and really in no one's interest to pay because they'll drive up costs in the system all for everyone, all across the healthcare system. In Alberta, we've been given prices $14,000 for surgeries that would be $5,000 or less covered under the public health system, $50,000 for outpatient knee replacement surgeries in Alberta for patients. I mean, just absolutely ludicrous prices that no Canadian should ever be paying in the first place. And to be clear, under the Canada Health Act, which is portable, portability is one of the 5 cornerstone principles of public Medicare in Canada. That means patients from coast to coast to coast are covered under the public health system. It is not a loophole that a private clinic can charge a patient from out of province. It is illegal, and it's up to the provinces to ensure that if patients are traveling between provinces, that those patients have a way of applying for that and that they're covered for that. And that physicians cannot operate inside and outside the public health system at the same time. Provinces could easily stop that practice, but they are not, and nor is the federal government. Moving on, thank you very much, Chris. Moving on to Manitoba now. Thomas Linner is the Provincial Director of the Manitoba Health Coalition.
Hi all. as Natalie says, I am the provincial director for the Manitoba Health Coalition. My name is Thomas Leonard. Just about 120 seconds ago, my computer went poof, and I was off of this. So my my speaking notes are not quite with me at the moment, but I'm going to do my best here. The Manitoba Health Coalition has long been concerned, watching what's happening in Ontario and seeing the connections that we can make with what is happening in Manitoba in regards to our public healthcare systems and the fact that our governments seem to be taking every opportunity to remove capacity from our public systems and place them into the hands of for-profit corporations where and whenever possible. One of the most distinct places that we can see this is in the operations of the COVID-19 Surgical and Diagnostic Recovery Task Force. That is a mouthful, but it exists in Manitoba. And it became very clear from the outset of that strategy that the goal was to move capacity from the public system to the private system, but not just the private system, to out of province and even out of country providers in North Dakota, Minnesota, Ohio, Arizona, California, different states throughout the United States to deal with everything from heart scans to hip and knee surgeries, starting mostly with the hip and knee surgeries in North Dakota, and doing these big deals with large medical corporations like the Mayo Clinic Health Systems and Sanford Health in the Dakotas. Now, doctors and physicians, nurses, frontline healthcare professionals have been concerned about this from the beginning. They've expressed their concerns with the lack of investment in capacity in Manitoba's system for the long term in taking these short-sighted decisions. They have raised concerns about the lack of transparency in these deals. Manitobans do not know and are not able to see the secret contracts that are being signed with these multi-million-dollar private US health corporations. And they have been concerned about the amount of travel that patients are being asked to take on behalf of the Manitoba government for some very complicated procedures, when what you want is to actually build up that capacity here at home to deal with that. Now, there's a number of concerns, and as I said, doctors are speaking out. Doctors Manitoba, which is the main body for physicians in Manitoba, has spoken out against these actions, as have very recently the head of neurosurgery at Health Sciences Center in Winnipeg, which Dr. Dan Roberts, HSC is the largest hospital in Manitoba, has spoken about his despair at seeing solutions within the public system be ignored by this task force, but when private corporations come with anything at all, they seem to have a special elixir, some kind of secret handshake. His words, not mine, in order to receive attention from this provincial government. We have had sleep specialists remove themselves from the task force because they were simply ignored for not bringing forward solutions with enough private options. And we've seen this on case after case, time after time, in regards to how this government is acting forward. My concern for the people of Ontario is the same as my concern for the people of Manitoba. Healthcare in Manitoba, Ontario, and across Canada is at a crossroads. We have the chance here to make the right decisions and make the real investments that will increase community health and support our public system for the long term. Unfortunately, our governments are making other choices. They are committing to short-term solutions that will only embolden for-profit operators who, when things get tough, are going to walk away. So with that, I'm done. Thank you, Natalie.
Thank you very much, Thomas. And next we have Juliet Bouchy, and Juliet is the provincial director for the Saskatchewan Health Coalition. Thanks, Juliet.
Thank you, Natalie, and good morning, everyone. I bring you greetings from Treaty 4 territory and the homeland of the Métis Nation. Like Thomas, I can't find my mouse, so I apologize here. I'm just going to be going back and forth. So when we look at healthcare privatization in Saskatchewan, it is a complex and has a long history here in the province. However, though, the reality is that, like many healthcare services themselves, the private sector has sadly occupied very important roles in different provinces and has contributed to so many healthcare challenges and mismanagement in Saskatchewan and other provinces, as we've heard this morning. And oftentimes our systems are not well programmed or even prepared to deal with the shortfalls imposed by private providers. And so the argument here is not if our healthcare system is public or private. However, it is what makes the Canadian healthcare system public is the extent to which these private deliverers of care are paid from public purse. Saskatchewan often like to private itself as being the birthplace of Medicare, and yet we have already allowed significant growth in the number of private for-profit facilities and providers that often, again, that offer everything from advanced diagnostic testing to a range of surgical procedures, like my colleague Chris has alluded. Just last month, the Saskatchewan, in March, the government of Saskatchewan actually announced a $6 million investment in private surgical company in Calgary to do knee and hip replacement for folks in Saskatchewan. And now, that news does not come with its consequences as well. Not everybody is opportune actually to have that opportunity to actually go to Calgary. A lot of people can't go to Calgary, can't travel, and so they are being delayed further as well. So unfortunately, some of these initiatives again have been actively encouraged by the provincial governments, while others have been again tolerated or quietly encouraged insofar as they are again deemed as providing a release valve, right, for the pressures on the publicly financed system. And so the argument is with the government is usually, well, we are finding ways, we're trying ways to, looking at ways to help our people that are in pain. But this is again, short gain for long-term pain. And so the issue here is the fact that a lot of the healthcare deliveries and services are being financed and paid out of the public pockets. So when we look at surgical wait times, especially in Saskatchewan, we're seeing an exponential increase in surgical wait times. Our nurses and healthcare professionals are understaffed, and overworked. We have a lot of overtime. People are working overtime, forced to work overtime, and with very little benefits and compensation to go with that. Our long-term care homes are overflowing, and again, the results and the solution from our provincial government is again to contract out with another private long-term care facility called Emmanuel Villa, which actually allowed the government to subsidize at least one resident with a monthly residential subsidy payable amount of $7,250,000. So one resident gets again over $7,000 to live in those private care homes, while our publicly funded care homes are in dilapidating states and short staff and overworked care aides. There was a research that was actually conducted here in Regina, and it was with new immigrants, and we're seeing as well that a lot of new immigrants there's an increased rate of self-medication because of the long wait times to see the doctor. You have to call to book an appointment to see a doctor, and when you get there, you wait as well to see a doctor. And when you get your medication, again, you wait to get your prescription. You also wait You just have to call in again to get your scans. You wait again to get your results. And so the long wait times in services are forcing and pushing a lot of residents to either self-medicate or having to rely on family members back home to import drugs for them and medication because they don't trust the healthcare system here. Nothing has improved, unfortunately. The appetite for privatization in Saskatchewan has been absolutely disgusting, and a lot of the solutions from the federal government again has always been privatization and more privatization. And so I will leave it here. Unfortunately, we are in a dire situation. Our public infrastructures are collapsing, and the government solution is to again sponsor and finance private for-profit providers and employers.
Okay, thank you very much, Juliet. I'm sorry to that it's bad news from Saskatchewan. And of course, you have these private pay where people are paying out of pocket directly for Canada Health Act covered services rather than improving the public system. So again, we're focused on surgical and diagnostic clinics, private for-profit surgical and diagnostic clinics, and the concrete lessons of privatization from across the country. And now I'm going to go further to the east, and I'm going to ask Bernadette Laundrie, who is the co-chair of the New Brunswick Health Coalition, to give us their experience in New Brunswick.
Yes, hi. Well, in New Brunswick, we have, up to now, we have 2 cataract surgery clinics, one that opened in Bathurst last year and one that opened in Miramichi. The one in Bathurst, the waiting list was 1,400 people, and the government gave $2.3 million to that clinic to do cataract surgeries. And it's officially a pilot project of 1 year. So that's a lot of money for just 1 year. In Miramichi, the waiting list was only 700 people, and they got the same amount of money, which means that if 700 people have cataract surgeries, it's going to cost each surgery over $3,000. So that's totally ridiculous. But what's even more alarming, the government just presented 2 bills in the House of Commons in Fredericton, and one is concerning private clinics to increase the number of private clinics. Beside that, there's another bill also that eliminates elected representatives from the boards of directors of our regional health authorities. We have a government that centralizes power within just a few people, and management of healthcare is given to for-profit companies. And that is very alarming, because we have a company like Medavi, for example, that manages the 811 number for people who want advice on healthcare. They telephone and get answers. They manage the extramural program, which is professional healthcare services at home. So they took that over. They took over the education part of some of the health professionals. So they're involved in education now, and little by little they're becoming our new Department of Health. And so they have an incredible influence on decisions that are being taken by the government. And it so happens that the response that the main head of Medavi is used to be he used to be the Prime Minister of New Brunswick in the Conservative Party. Now we have Blaine Higgs, who is also a Conservative, and they get along very well. It's really scary to see that not only are private clinics being opening everywhere, but now the whole management of the system is being given to the private sector. So that is very alarming. That's about what I have to say as far as New Brunswick is concerned.
Thank you very much, Bernadette. Merci. And for just to summarize to this point, we have some provinces in which there are very few private clinics, and they're very much in their infancy. New Brunswick as an example, Manitoba as another example, and other provinces like British Columbia, Alberta, Saskatchewan, where we have existing larger for profit clinics doing surgeries and diagnostics, and the lessons of what those clinics have done in those provinces to take for the rest of the country. We have just two brief speakers left, and then we'll open for questions and answers. I'm going to turn to Alexandra Rose now. Alexandra is the provincial coordinator of the Nova Scotia Health Coalition. Welcome, Alexandra.
Hi, everybody. Thank you for having me. So although our small Atlantic province may seem far removed from Ontario and other Western provinces, the state of our public healthcare system affects everybody. So like many other provinces, we're no strangers to overcrowded emergency departments, unprecedented wait times, and staffing shortages across all healthcare areas. Nova Scotia has also been facing challenges regarding privatization, as well as its own unique challenges within our healthcare system, most predominantly the shortage of family doctors. So our primary care physician waitlist has just reached 145,000 Nova Scotians. That is 145,000 Nova Scotians who do not have access to consistent primary care, and 145,000 Nova Scotians who must visit emergency departments for non-emergency issues, contributing to the overcrowding simply because they have no other choice. We're all familiar with the claims from private clinics that they have the potential to ease the burden on the healthcare system by keeping people out of emergency departments by providing access to primary care. The staff for these clinics do not appear out of thin air. There's a set amount of healthcare workers, and every healthcare provider that joins a private clinic is one that is leaving our public system. Here in Nova Scotia, we have seen a lack of success with private clinics. Just one example, this past summer, we saw a private clinic open in Dartmouth that at the time of opening claimed they had over 200 patients pre-register for their $22 a month subscription service, plus an additional $20 fee per each visit. Their claims of reducing wait times and easing the burden on Nova Scotia's healthcare system fell flat when just 6 months later, with seemingly no warning, the clinic closed. Offices were dark, voicemails never answered, and the website shut down. Needless to say, this did not ease the burden on our public healthcare system. This is just one example, but it is not the only example of for-profit private delivery falling short on their claims within our province. We face a similar issue as Ontario this year, resulting in clawbacks to federal health transfers. Nova Scotia allowed for a for-profit diagnostic imaging company to offer faster service for MRIs, arthroscopes, and ultrasounds for patients who can afford to pay. Funding like that is intended to support our public healthcare system that we, like you, will no longer see, causing a further strain on our healthcare system. Bill 60 allows for privately owned clinics to perform OHIP-covered surgeries. This has been described as a necessary step to reducing a large surgical backlog. These statements are all too familiar to us as well. In December of 2021, the decision was made to expand the contract that the Nova Scotia provincial government has with the private surgery clinic, Scotia Surgery, to reduce the surgical backlog and to reduce wait times. As of February 2023, Nova Scotia has not met its own self-imposed deadline to reduce this surgical waitlist. National benchmark figures tell us that Nova Scotia's surgical waitlist should be around 12,000 people. As of February 2023, that number sits at 21,500 people. This is yet another private solution that has not achieved its goals, leaving over 21,000 Nova Scotians unable to access the care they need in a timely manner. for-profit private healthcare delivery is not and has never been in the best interest of people. We draw these conclusions based on data, facts, and personal experience of Nova Scotians, and the solution to fixing our public healthcare system is not to pass the buck to private for-profit entities. Thank you.
Thank you very much, Alexandra. And last but not least, we have Mary Boyd, and Mary Boyd is the chair of the PEI Health Coalition. Mary, you're muted.
Okay.
There you go.
We're such a small province that we feel the least of all the inputs here, and it's kind of blows your mind to hear what the other provinces are reporting. We just had an election here, and healthcare was the #1 issue, but one of the problems listening to the different political parties and the debates was that they were not getting deep enough into, the problems facing our system and how we change those. And so it's hard to tell where we're going right now because we have extreme staff shortages, physicians, specialists, nurses, and the nurses are very much overworked. In addition to that, there is a privatization element coming in because traveling nurses are coming in paid much more than our average PEI nurse, and they're coming in and taking over positions. And there's just been a big discussion about that, about how the PEI nurses are going to be able to get some vacation time this summer because they've been doing extra shifts. They've been overworked to the point where there's a lot of burnout. And so will they have an assurance that they're going to get some rest and recreation this summer? It's been a long haul for all our nurses and for our staff. And so with a situation like that, it's hard to know where things are going. Surgeries here are under the public system, and but islanders have to go out of the province for many of the specialized surgeries, either to Halifax or to Moncton or to St. John, New Brunswick. So in a sense, the maritime provinces have a lot in common on the questions of healthcare. And even though we have 3 separate provinces and 3 separate premiers, the big news and concern right now, because of the shortage of staff, is around the closing of ICUs. At the moment, the only ICU that's open is in the Queen Elizabeth Hospital because there's no staff at the other places. And the same with emergency. And there was a figure came out about the closing, the number of hours lost with ICU closings. And I just listened to the news before I came on here, and it blew my mind because I'm pretty sure I heard them saying that the hours of closures were up 1,300% from 21 to 22. I have to check those figures, but all day long, there's announcements coming out about how many lost hours there are for ICU and also for emergency. And so this is, and part of the loss of staff is when nurses can't endure these long hours and problems, they go to DVA because we have the headquarters of the Department of Veterans Affairs here in Charlottetown. And so we know we're not free of privatization. And so we're looking at just exactly how that works out. But just to say, I'm very shocked when I see that such a bill as Bill 60 would be passed in a Canadian legislature. It's a destructive bill and has implications not only for citizens of Ontario, but for all Canadians. And there are alternatives to the problems currently experienced by Canada's public healthcare system. But Bill 60 will exacerbate those problems and not be any help at all to us. And it could set a precedent for the whole of Canada. And we just can't believe that such a thing has actually been passed in the legislature, as I said. And we all know, and we said a two-tier healthcare privatization is no answer for public healthcare system problems. Privatization as a solution has been well researched and found wanting. And it costs the government so much money to maintain such a system. And so if I look on PEI, we have a private delivery of healthcare under MAPLE. It's well entrenched here, and patients are using this corporate model, and they're given free access from 8 a.m. to 4 p.m. So that means that PEI government pays MAPLE for all of the appointments and consultations from 8 in the morning till 4 in the afternoon. But after that, if patients contact MAPLE, they have to pay out of pocket. Now the government is promising to increase the hours that MAPLE will operate at government expense. This is a very expensive way to operate a healthcare system. The more healthcare money that goes to the private sector, the less there will be for the public system and other necessary services. PEI is the most household insecure province, food insecure province in Canada at 23.6%, and that's up from 16.5% in 2021. And children are the most food insecure at 35.1%. So many of those children are from working class families, and PEI has the lowest wages in the country. And these numbers mean less healthy population and more strain on our public healthcare system. Spending more dollars on private healthcare has had all kinds of detrimental effects on all aspects of healthcare and on the social safety net. So that's one of our really big worries now. Can I just close with a few more comments?
Sure, just, yep.
Yeah, Canadian core values place high value on healthcare based on need and not ability to pay. We're proud of our public system, which ranks in the top 4 contributors to national pride. There's a big danger that decisions like Bill 60 could lessen our quality of healthcare. It does violate the Canada Health Act, and every effort must be made to see that it's not implemented. There are many great examples of how wait times can be reduced in the public system. There are international ones, such as what they've done in Scotland, and there are many made in Canada solutions. It's time that we made those public solutions permanent in Canada and in all the provinces.
Thank you so much, Mary. Thank you very, very much. Okay, so just to wrap up, most of our communities across the country have spent more than 100 years building up our public hospital system. Many of our hospitals started as charitable or from religious orders or as municipal public hospitals. It is no accident that public health insurance for hospital services and physician services grew inextricably intertwined with the growth and the creation of a public hospital system across the country. It is also no accident that with the dismantling of that public hospital system, we are seeing the growth of private for-profit two-tier healthcare and extra charges for patients. This we can see clearly in the provinces where they have brought in for-profit hospitals and surgical centers, which are essentially day hospitals, to take over what were once our public and nonprofit services. In the provinces where they have moved in, we have clear evidence that the promised improvements to wait times have not happened, that costs have increased dramatically, both government costs and costs for patients. Indeed, we all agree that the status quo is not sustainable. As Thomas said, this country is at a crossroads where provinces that have not yet started to privatize the ownership and control of our public hospitals are starting down that path and following provinces where we have already seen the destruction of single-tier public Medicare and incredible problems trying to control the private clinics in their provinces after they gain foothold. And so, thank you to my colleagues from across Canada for bringing your warnings about what is now being undertaken in Ontario if we don't stop it. And just to say that all of us are advocating for patients access to care under the principles that govern public Medicare, about which Canadians are so proud. Principles of equity and compassion, not profiteering, extra costs, user fees, and queue jumping for the rich. And we'll open it up with that for questions from the media. Britt, you're gonna moderate this?
Yes, absolutely. If there's any questions, please raise your hand or put them in the chat.
In the chat. If you can, you don't have to put your question in the chat, just indicate that you've got one. Thank you. Any questions from media?
So Tina Yazdini from City TV News.
Hi, everyone. I actually wanted to ask about the Alberta study that was just released. I'm just looking at it right now, and the one of the notes is that it actually did improve, I guess, wait times for cataract patients. Do you see any benefit at all, in terms of getting some of those lower cost procedures done outside of hospitals, seeing as, it looks like it was the share of patients meeting the benchmark increased. It was the largest increase among the provinces when ASI was implemented. Just your thoughts on that.
So Chris or Noel?
Yeah, I'll jump in on that. In Alberta, we've basically privatized all of our cataract surgeries at this point. It's a highly privatized industry. And at the time that the minister announced the most recent contracts for those surgeries, he was asked, could a future government change this decision and do these in-house? And he said, we would be locking ourselves into a long-term contract with guaranteed volumes of surgeries, of cataract surgeries. We don't know what's in that contract because as the public, we don't get to see these contracts. That's part of the accountability and control piece that we lose when we do this. So we don't know if we're paying for more surgeries, if we're paying more per surgery. We don't have answers to those questions. So there's no way to compare whether it was a better decision to do this versus doing it in the public system because we have no way of knowing. We're not privy to that information. We have heard stories over the years of a lot of upselling in ophthalmology and concerns with patients who come in and get offered extra services or different added forms of treatment while they're there that they pay out of pocket for on top of the covered surgery. So we're concerned because the accountability piece isn't there. So we don't really know what's happening with those cataract surgeries other than those few numbers that the province releases.
If I might answer for Ontario, like we know that the private cataract surgeries actually cost more. So they're funded at $605 per eye. Under the public system, in public hospitals, it's $500 to $550. So it's $50 more per procedure. Obviously, if you paid that to public hospitals, you could buy more procedures in the public hospitals. And of course, the staff comes, out of the public system. So, I mean, the question is, we're going to pay for it anyway. Or do we want to pay more and send patients to places where we know that they are routinely trying to upsell an increasing myriad of medically unnecessary stuff, including some junk, and also outright misleading patients. We have people that are routinely told that laser eye surgery for cataracts is not covered in private clinics. They tell people that it's not covered in the public system. It is expressly covered by OHIP. That's a lie. The patients are being told. They're being told that they need to pay for just an increasing, very confusing array of laser eye vision correction and other modalities of eye surgery and so on. They're told that they need to do this. They're told that they need extra eye measurement tests, $200 per eye, when the OHIP covered test shows the same efficacy, shows the same medical results. That's according to the expert panel that determines what things are covered by OHIP and not covered by OHIP. So these are elderly patients, most of them on fixed incomes, being upsold and extra billed and manipulated to pay a lot more for their cataract surgeries in the private clinics that are already being funded at a higher rate by the public system. Why would we do that? I mean, obviously, if you increase volumes, period, you would reduce wait times. However, if you increase volumes at much higher cost, you will not reduce wait times comparatively if you reduce the volumes at a lower cost. And, you know, the evidence from across the country shows that the costs are higher and that for patients, they're being billed just really asinine prices for these surgeries. I mean, way, way, way beyond anything that could be considered the cost of the surgery. And then Burnett, did you want to say something from New Brunswick?
Yes, I just wanted to add that there was also a study in Quebec that came out, I think, about a month ago, and it came to the same conclusion that it cost an average of $780 for cataract surgeries in the public system, but it's over 1,000, I think it's 1,300 in the private system.
Excellent, thank you. Are there any other questions from the media?
Sorry, I had one more, if that's okay. I'll just throw it out to the group. Just, you know, we're hearing examples from coast to coast that this isn't working. Why, you know, why do you think so many governments have decided to go in this direction despite that?
And so I just want to, because I was worried listening to everyone as well, just to put it in context, the vast majority of surgeries and diagnostics like MRIs and CTs are still done in public hospitals across Canada. And when we're talking about the private clinics, even in the provinces that are sort of ground zero for private clinics, I'd say BC, Quebec, possibly Alberta, you know, ground zero for the amount of privatization of these services in Canada. Even so, the vast majority of surgeries and diagnostics are done in public hospitals. And what we're talking about are the rampant examples of extra billing and user fees and all of those sorts of things that are happening in these clinics. In our province, you know, there is no justification for this. Everyone agrees that the status quo is unsustainable, but we have operating rooms in every public hospital that operate from 8 a.m. till 4 p.m. Even in the largest hospitals, we might have operating rooms, 1 or 2 at most, operating on the weekends and in the evenings. And so we have this OR time. We built it. We paid for it over a century in this province. All of us did. Why would we pay again to rebuild in a private for-profit clinic? In whose interest is this? The only interest that it serves are the lobbyists and the corporate owners of these private for-profit clinics. And that's why it's happening. I don't know if Noel, Chris, and Thomas. Noel, do you want to go ahead from BC?
Can I actually, I'm going to say this and then I'm going to leave.
Okay, sure.
Because I have another event that I have to go to here in sunny Winnipeg. But I'll just say that I think we've all in our work noted that there is quite a bit of even if it's not coordination, it's the same pattern emerging over and over again. We are seeing governments who have been committed before and during the COVID-19 pandemic to reducing healthcare costs, to making deep cuts, which sows chaos in our healthcare system, and just allows those private providers to have that much more say and being able to sell privatization as a silver bullet. We've seen it from moment one in Manitoba, and I know that it's been happening in other provinces as well. This is a really well coordinated kind of effort. We've seen the groups such as Cambie Surgeries, who have been involved in the court case that Noel was speaking about earlier from BC, but they're not alone. There is a big movement from a lot of these private providers to swoop in and try to capitalize on the difficulties that we are seeing in Canada's healthcare system. And I'm telling you right now that what it is doing is it is turning government's eyes, and it's turning media's eyes, and it's turning public's eyes away from the actual solutions that they are. We are losing time, money, and healthcare professionals to really what appears to be a privatization fetish. And I think that the people here on this call have pretty much had enough. Now I've got to go to another thing. If anybody ever wants to call me, I've got a phone number. Bye now.
Thank you, Thomas. Okay, then Noel and then Chris.
I'll let Chris go and then I can go.
Okay. I think it comes down to ideology. You know, we've had here in Alberta these premiers who sign public health guarantees and then proceed to privatize everything they can. And they do it under the guise of it's publicly funded, so it's not privatization. But why would we use our public healthcare dollars to fund profit instead of paying for public healthcare with it? So it's an ideology. You know, with surgeries, they told us it would get more surgeries done, it would shorten wait lists, and it would save us money. And it's done none of those things. So their bill they're selling to Albertans saying this is what will happen doesn't happen when it actually gets implemented. Really, it's about privatization and it's about profit for certain interests. They're not saying that up front, but that is what they're doing. It's very clear. And all their claims and all these different contracts we've signed the last few years about how it'll improve service and save us money never come true once we turn the services over to those private providers. So we need to call that out.
I can't claim that I know the motivations of the government here in BC around privatization, but what I can say is if I was in their position and I had long wait times, I would want to make it seem like I was doing something to solve the issue and also simultaneously displace the responsibility of the crisis elsewhere. So I think that it could be a strategy, although it's very short-sighted. Again, it doesn't solve the root causes of the problem, but in the short term, it makes it seem like there's some activity and that there is some seriousness being taken around the issue.
Thank you. Thanks, Tina, for the questions. Anyone else have any questions from the media? Oh, sorry, Bernadette, did I give you a chance? Did you want to say something? No, you're okay. Okay. Okay, so we're going to go to Twitter Spaces. Maddie, go ahead. And with this, we'll end the sort of formal part of the press conference. Thank you to the media who are here, but we'll just go to questions from Twitter Spaces and from the Facebook live stream. So Maddie.
So we have a question from Christine that I'm going to read, and we also have somebody who's asked to be able to speak. So to that person, if you would like to ask your question after I read this question, you're welcome to do that. So the question from Christine, and Christine's a CBC journalist who's linking to an article about patients suffering due to overcrowding and understaffing in BC at Surrey Memorial Hospital. The question is, any comments on this happening in BC? Health officials won't publicly admit scale of crisis at Surrey Memorial Hospital ER in doctor's letter.
Okay, Noel.
Again, I can't say to speak for public officials and what they're commenting or not commenting, but I think that the issue of emergency rooms, although isn't a topic that we have been discussing here today, we're more focused on surgeries. But I think that when you look at primary care, surgical care, diagnostics, it all comes back to the same thing, and that's a shortage of workers and a shortage of capacity in that sense.
Great, thank you. And we'll give a chance to the person who asked to be made a speaker if you'd like to ask a question now.
Thank you. And I'm guessing other people on that call can't actually hear me. You'll have to repeat this.
They can hear you. You're on mute.
Oh, amazing. Hi. So yes, I am a Canadian healthcare worker currently working in the States. I've had the opportunity to work in Australia as well, another two-tier healthcare system. We've seen a lot from the evidence that's been displayed that these systems don't work for the most vulnerable populations, and that it'll end up hurting Canadians overall. Especially with Ontario with Bill 60, my question is, how can we stop privatization? How do we push back? I think historically, within my limited lifetime, both under the Ford government and the Wynne government, they don't listen to healthcare professionals. The OMA has been powerless to do anything that make these kind of changes. These provincial health coalitions, which are amazing. I following on Facebook for a very long time. They don't listen to us. How can we stop it if they won't listen? If the governments do whatever they want anyway?
I'm going to take that one if that's okay. The truth is that we actually have stopped the private clinics in Ontario multiple times. Under the last government, they tried to bring in private surgeries and diagnostics. We held a mini referendum at that time. We held protests. We, did petitions. I met with the premier and the health minister repeatedly, and ultimately they agreed to stop the for-profit privatization of our surgeries and MRIs and CT. So that did actually work. And even under this government, the Ford government leading into the pandemic, they tried massive cuts to public health. They tried to merge the public health units from 43 down to somewhere between 10 and 20. They kept changing what it was going to be, as well as ambulance services and potentially privatize the ambulance services. We held mass protests across the province. They also made cuts to long-term care, which we were managed along with municipalities and others to reverse and stop. In this case, we're calling a massive people's referendum. We have about 1,000 voting stations set up outside grocery stores and corner stores and at Legions and other public places all across the province. In small towns and large cities, we're asking people to vote en masse. Where we have more than the first 100,000 votes in, well over the first 100,000. We're aiming to try to get 1 million votes. We have votes in workplaces, both unionized and non-unionized workplaces. People who are concerned about this all across Ontario are helping in every possible way. And so our first step is to hold a referendum to try and force democracy where there has been none. And like in the other provinces, people have never really had a say over this largely. And so we're trying to sort of create democracy. And if that isn't followed, we'll ratchet it up. And we'll keep ratcheting it up until they stop. They have no mandate to do this here, none whatsoever. And we will not stop until they stop. These hospitals, literally our communities, as I said, have spent a century, more than a century building them. We've funded them, we've donated from our paychecks, volunteered at them. We've built them to build services closer to home, not to build cataract factories that are centralized, that take all the volumes for the region and shut them down in all our local public hospitals. Like, that is not a model of care that Ontarians support. And we're not going to tolerate it. So, I mean, it's a question of, civil action, just like anything else. And, she who puts on the most pressure and is the most relentless wins. And, we have a good history of that, and we will do that here. Thanks for the question. It's a good one. Okay, I think we'll go to Facebook now, if that's okay. Lubaba, you got some questions on Facebook?
Yes, thank you, Natalie.
And then we'll close.
Thank you to folks on Facebook for your wonderful questions. Sorry, we had someone from Facebook ask, and this is for Alberta, since a lot of public dollars are going into funding these private systems, why aren't these contracts available for public?
Yeah, that's always the case with these public-private contracts, right? That they're proprietary to the private business and the public doesn't get to see them, whether it's in healthcare or education or P3 public-private trains that we've built in Alberta, etc. We don't get to see the details. We're just left holding the bag if something goes wrong in the end. So it's a real accountability problem, and it's a real control problem. Because the other thing that can happen, as we've seen in Alberta, is, in Calgary, we had the surgical center that closed. It went under, and then we had to take that on, right? In the end, it's on the public to deal with these services. We're providing these services, and if we're paying a for-profit company to do it, they don't have to keep doing it. We've seen that in seniors care and elsewhere, where these private corporations just walk away, and then we're left without the care that people need. So yeah, we don't get to see the contracts. It's an accountability issue, it's a transparency issue, and it's also a control over making decisions in the system issue.
Thank you. That happened with the Dynacare labs in Ontario too. They closed down a whole bunch of small town for-profit labs. Anyone else on that? So this, I think, is the same across the country. Once they privatize it, the legislation that covers public access to information exempts or excludes private contracts with private providers as a commercial secret, and they're allowed to shield them from public scrutiny. And it takes just a hell of a lot of effort to try and get those contracts disclosed. We have done it, for example, in the Cancer Treatment Center in Ontario, where ultimately, dogged effort by both the Liberal and NDP opposition parties revealed that the contract was $500 and $2,001 more expensive per cancer treatment. We've got it for the cataract surgeries in Ontario, where we know they're more expensive as well, but it's very, very hard to get these contracts disclosed. Are there any more questions on Facebook? Lubaba?
At the moment, that's about all we have.
Okay, good. So are anyone else? Did anyone else want to say anything in closing from the provinces? Okay, thank you very, very much, everyone. I think this has been really illuminating for people. And, thank you for bringing kind of the real consequences from, and also the state of public health care across the country, really painting a picture in very concrete terms for people about what's going on. I think as we said, that the consensus is that the status quo is unsustainable. The question, though, is whether we hand our public ownership and control over to private for-profit entities to rebuild the system in their interests, or whether we build and restore and build capacity in the public interest going forward. And that really is the fundamental question. And it has profound implications for equity, for compassion, for control of care going forward. Bernadette, and then we'll end.
I just wanted to say, because the problem is all over the country, I think it would be important that there be a national strategy to counter privatization, because we're all in the same boat at this point.
Absolutely. Thank you. Okay, so we'll end this for today. Thank you very, very much, everyone. Thank you to everyone who joined the live streams as well in Twitter Spaces. Bye now.